You can start now.
Okay, ma'am. Namaste and greetings. I, Priyanka, researcher at IMPRI, Impact and Policy Research Institute, Prabhav on Niti Anusandhan Sansthan, Nai Delhi, extend my warmest welcome to you all to IMPRI Web Policy Talk. We are gathered here today for the IMPRI 7th annual series of thematic deliberation and analysis of the Union budget for the financial year 2026-27. As part of this series, we will be engaging in a panel discussion on population, health, and union budget 2026-27. This discussion is organized by the IMPRI Center for Human Dignity and Development under the IMPRI Web Policy Talk series. I warmly welcome all of you to this insightful deliberation and thank you for tuning in. The chair and moderator is Dr. Manorama Bakshi, G, Director and Head of Healthcare Advocacy, Consortia Advisory, Founder and Director of Trilok Raj Foundation, visiting Senior Fellow at IMPRI. Today, expert panelists include Dr. Shoba Suri Ji, Senior Fellow, Health Initiative, Observer Research Foundation, Dr. Urvashi Prasad Ji, Ex-Director, Office of Vice Chairman, Niti Aayog, Professor Sanghmitra Sheel Acharya Ji, Professor, Center of Social Medicine and Community Health, J- JNU, Dr. Praveen Aggarwal Ji, Co-founder and Director of Consortia Advisory, Mr. Abhijit Mukhopadhyay Ji, Senior Research Consultant, Chintan Research Foundation, New Delhi, Mr. Varun Sharma Ji, Senior Specialist, Monitoring and Evaluation, Population Foundation of India. The conveners of the program are Dr. Simi Mehta ji and Dr. Arjun Kumar ji. To begin today's discussion, I am honored to invite Dr. Manorama Bakshi ji, Chair and Moderator, to share her opening remarks. We welcome you and over to you, ma'am.
Thank you very much, Priyanka. Good afternoon to all the colleagues. It's rather good morning. Good morning to all my colleagues, panelists, participants. We have today experienced panelists who will guide us through the analysis and deep understanding of the health budget. Right now, I'll be discussing the Union Budget 26-27. And this is the time when India's health challenges are no longer limited to excess or episodic illness. They are increasingly shaped by deeper structural transition, demographic aging, a rising burden of NCDs, around 60% of mortality coming from NCDs, and the growing implications these trends have for the productivity, care systems, and long-term economic resilience. Actually, I believe it's important to begin by clearly laying out what the budget has provided for health sector before we move to interpretations, analysis, and perspective of our expert panel. Let me therefore start with headlines. I'll be saying what budget gave us. For 26-27, the total allocation to the Ministry of Health and Family Welfare stands at 1,06,530.42 crore, representing roughly a 10% increase over the revised estimate of the previous year. Importantly, this is the first time India's health budget has crossed the 1 lakh mark. This is a symbolic and physical milestone. I'm not actually referring to the slide. I'll be going a bit like sharing my experiences, but then I will come to the slide. I have just 4 slides. I want our experts to speak more. So when we are talking, like this is a symbolic and physical milestone actually. But at the same time, it signals that we need to think like how the prioritization happens. As we all know that we don't have a lot of money, the whole of the money of the world. So how we prioritize, how our policy think tanks think, and how the budget has been allocated. It signals that even though we have 10% increase, that there is some greater visibility within the national spending priorities and reflects an acknowledgement of its growing importance in the health development trajectory. But what matters is how these numbers translate into system capacity, resilience, long term outcomes, and what we will examine as we produce. Within this total budget of 1.06 lakh crores, the Department of Health and Family Welfare received 1 lakh 1709.2 crore, accounting to a share of the expenditure. The Department of Health Research received 4,821 crore, reflecting an increase of 24% over the last year. Beyond aggregate numbers, the budget introduces several notable policy measures. For the first time, the Biopharma Shakti initiative, with an outlay of 10,000 crores over the 5 years, aims to position India as global hub for the biologics biosimilars. This initiative recognizes growing burden of the disease such as cancer, diabetes, autoimmune diseases, and strategic importance of biologics medicines in managing them, and Atmanirbhar Bharat. Now, as we look, we are talking about the Viksit Bharat 2047. The second thing that budget proposed was the establishment of the 5 regional medical value tourism hubs designed to integrate healthcare complexes, combining medical service, education, research, OU centers, diagnostics, and rehabilitation. This aligns health policy with employment generation, exports, and India's global healthcare footprint. Third, there is a clear emphasis on health workforce, particularly allied health professionals. The budget proposed upgrading existing allied health professional institutions, establishing new ones across 10 disciplines, including optometry, radiology, anesthesia, OT, applied psychology, behavioral health, with a target of adding 1 lakh allied health professionals over the 5 years. Fourth, the budget introduced a care ecosystem focusing on geriatric and allied care services. So, multi-skilled caregivers aims to train 1.5 lakh caregivers in the coming year. It is important acknowledgement of India's aging population and growing demand for the long-term care. Fifth, the budget introduced is to strengthen Ayush and traditional medicines, including New India Institutes of Ayurveda, and enhance global facing research and certification capacity. Sixth, the area of mental health. The budget announces a new NIMHANS in North India, along with the upgrades to mental health institutes in Ranchi and Tezpur. Finally, the budget addressed the drug affordability by introducing customs duty waivers and relief on select cancer and rare disease drugs. Taken together, these measures demonstrate intent, breadth, and responsiveness to some of the emerging health priorities. But what does it actually mean as a professional, as a public health professional? Having acknowledged these positive provisions, it is important to examine what this really means. On actual terms, if we will see the real growth versus the inflation, while the health budget has increased by about 10% nominally, medical inflation driven by drugs, diagnostics, technology, workforce remains in range of around 8%. Added to this are the population growth and aging pressures, which is another 1 to 2%, which are not explicitly priced into inflation indices. Once these factors are accounted for, the real physical expansion is actually very marginal. In practical terms, this budget largely sustains the existing systems rather than creating significant new capacity. Second, the balance between the service delivery and research remains a bit skewed. Nearly 95% of the health spending flows into Department of Health and Family Welfare, while only 4.5% goes to the health research. This is modest, even though it is almost 24% higher than the last year. But looking at India's epidemiological transition, where NCDs account for almost 60 to 70% of mortality, where preparedness of pandemics and AMR and climate related health risk is increasing critically. So I think there should have been a good provision for the health research. Third, the treatment and hospitals continue to dominate spending. Large allocations flow to central hospitals, tertiary hospitals, infrastructural schemes, disease specific programs. These are necessary investments, but the primary prevention has taken a backstage. Public health surveillance, community led interventions have not been proportionately scaled despite clear evidence they offer. Ayushman Bharat Mandirs, right now we have 1 point around 80 lakh, that needs to be strengthened. Fourth, while initiatives such as Biopharma Shakti and medical tourism hubs send a very strong strategic signals aligned with the Make in India, Vikasit Bharat, job creation and exports. However, their population health impact will depend on execution, specifically on public procurement policies, pricing and affordability, integration within the public health planning. Fifth, the budget rightly recognizes workforce gaps through caregiver and allied health professionals. However, budget documents do not really clarify how these workers will be absorbed into public systems. Is it that the same, whatever we have the ASHAs and ANMs, will they be trained on this another work or there will be a separate cadre? That also needs to be very clearly identified. However, the wage protection and care progression will be ensured. How deployment will prioritize undeserved geographies. Training without deployment risks creating skilled but underutilized human capital. A balanced bridge to now is it appropriate to acknowledge Budget 26-27 has taken meaningful steps, particularly in workforce skilling, strategic manufacturing, mental health infrastructure, care services? At the same time, when viewed through the lens of India's demography and disease realities, the budget stops short of deeper reframing. Health continues to be treated primarily as social expenditure rather than an economic infrastructure that protects productivity, reduces long term costs. In the end, my close reflection is Budget 26-27 reflects stability, intent, and selective ambition. It marks progress, but not yet transformation. The central challenge ahead is to move from institutions to systems, from treatment also to prevention, and from welfare logic to economic logic. Until productive loss, unpaid care burdens, aging, chronic disease management are explicitly financed at scale, India will continue to pay sickness rather than invest in sustained prosperity. Because health is not merely the outcome of development, health is the foundation of basic development. Thank you. Sana?
Thank you, ma'am.
Yeah. Now let's
Thank you
start
for
with the
a very
panelists.
okay. Yeah, setting the tone of this crucial discussion, and we can start with all the panelists.
So I request Dr. Urvashi Prasad ji, our first speaker, to speak on Health Budget 26-27. She'll be talking about the hits and misses. Over to you, Urvashi ji.
Thank you, Dr. Manorama. You always set the context really very well. Of course, I think you are also very polite in how you put a lot of things. I am known to be less polite, less diplomatic, maybe. So, we'll see how that goes. But I'm speaking about the hits and misses. So if we start with some of the positives, which I think, you've already outlined a lot of them. So, I wouldn't spend a lot of time. But yes, in absolute terms, the health budget has gone up. I think it goes up pretty much every year. if you look at it, in terms of absolute numbers and percentages. But as we know, that is not really the correct metric to be looking at. As a percentage of GDP, we are still not even at 2% of public health expenditure. And that is something that we had said way back in the National Health Policy of 2017. So next year, it'll be 10 years of that policy coming out. And we haven't even hit the 2% mark. So, when we say that we are seeing ambition, we are seeing commitment, I don't know, because I would really believe that if we had at least hit the 2.5% mark, which we have said in our own national health policy. This is not somebody else coming and saying that. And of course, we know that countries across the world in our neighborhood are spending anywhere between 4 to 6% of their GDP often on health. And like you rightly put it, that it's still seen as a expense rather than an investment in the future, in the present, in the future, an investment in the workforce, an investment in our demographic dividend. The number of young adults like myself who are afflicted with very serious health conditions, which have actually nothing to do with us. We always talk about having a good lifestyle. And I don't know anyone, with a better lifestyle than what I've had. But I got my, lung cancer due to the air pollution. And we've seen budget cuts, in fact, for curbing pollution. So I don't know, I don't know where the intent really is. We'll soon come up to 80 years after independence, and we are still very happy with these 10% rises, year on year. I'm certainly not. As a public health professional, as a policy professional, as a patient advocate, this does not, impress me in any way. So I think that's what I would say for starters. Yes, in principle, the biopharma, Shakti and research funding, indeed, in principle, nobody can disagree with it. There's also been an expansion of clinical trial sites that has been announced. But of course, as we know, the devil in all of this lies with the execution. Last budget, we had the cancer care centers announced, and a lot of them, we are still struggling to, even begin to set up. So I think announcements are great, but, we'll have to always wait and see how the execution happens. I think clinical trials, India has historically a very troubled history. And which is why Mr. Keshav Desi Raju, who was the Union Health Secretary several years back, who I knew personally, had actually tightened the clinical trial rules significantly because we were having a lot of malpractices, given that most of our population is still very poor. What does informed consent really mean for them? So I know that we've moved ahead of that, and there's been a lot that's happened after that. But I think we'll still need to be cautious when we are talking about these things and their execution. So that would be my second point. The third would be that we've seen duty exemptions on certain cancer drugs, but they will reduce the overall treatment costs by only about 5 to 10%. So for patients paying out of pocket, there's still a huge burden on them. And we must remember that India imports hundreds of oncology molecules. So 17 is a good start, but we have hundreds of oncology molecules that we import, which are outside of this list, including the drug that I take, the targeted therapy, which is neither covered in Ayushman Bharat. And of course, unless you have private health insurance, you will not, get any sort of cover for that. And it can be several lakhs a month, the cost of that. So I think 99.9% of India cannot really afford it. So I think there's a long way to go on this front as well. Of course, we always welcome whatever comes our way, but I think we need to set the bar much higher, in my opinion. Mental health and geriatric care, again, long overdue. That we've received a little bit of prioritization in this in terms of the budget, the caregivers, training of the caregivers, the allied health professionals. I think even when I was at Niti, we used to say this all the time, that your health workforce is not just doctors and specialists. You need many other types of professionals who are trained, and there is accreditation, there is certification, there is a quality control. So, again, we'll have to see how all of that pans out. Numbers is one thing, but the quality is very important. But per se, of course, even the acknowledgement that we are also aging, and we have only a narrow window of opportunity actually for this demographic dividend that we talk about. I think that was good. Some of the other, I would say downsides, primary care, I feel has still been underfunded, still been neglected. You mentioned that a lot of the funding goes to, secondary, tertiary care, setting up new institutions, and that's all welcome, but it cannot be at the cost of, and again, this is something we've been saying, I think, for decades, that we are such a secondary, tertiary care focused health system, not enough going into the Ayushman Arogya Mandirs, because just numbers are not enough. But you can visit a lot of these centers, as I have, and most of the things that are supposed to be happening there are not actually happening. So I think that is a huge gap, in my opinion, because we cannot keep pushing everyone into hospitals. We have to keep people outside of hospitals as much as possible. We have a huge population. And I think in links to that, like I said, the environmental health cuts are extremely disappointing. We cannot be sitting here in Delhi, which is, I think, the pollution hub of the world, and cutting pollution control budgets. I mean, it's just delusional. I don't have any other words for that. So there's uranium in our groundwater, there's air, it's totally unbreathable. We rejoice when there is 200, 300 AQI. It's so unacceptable, and it is so basic. It's not rocket science, it's not artificial intelligence that we need here. We need the basics to be right. Public schemes, like I said, PMJ, they still exclude a lot of the therapies that people actually need, targeted therapies, immunotherapies. Cancer care around the world has moved way behind, ahead of chemotherapies. The stereotypical patient in a hospital getting a chemotherapy infusion. Yes, it happens with many even today. But for many types of cancers, the world has moved way ahead of that, and we are on targeted therapies, we are on oral pills, like I am. But they remain unaffordable for most of our people. Every day, I have people coming to me begging for money, to survive, to get their next set of pills. And how unacceptable is that? That somebody in the US can take those pills and live, 10 years, 15 years, even with stage 4 cancer. But in India, simply because of lack of affordability, people can't live, they don't survive. And I see those people every single day. So I think that's a huge gap in our public insurance schemes. Um, and I think that, I would have liked to see more in terms of equity. Some of the benefits may skew, like they always do, towards urban, higher income populations. So I think I would have liked to see more explicit call outs for rural, marginalized groups, gender sensitive and occupation specific health interventions, because I think occupational health is very neglected as well. And lastly, a couple of points. I think Ayush, you mentioned, um, what I see with Ayush, and what you said, that, we are focusing so much on service delivery. But where's the research? I'm just coming, a day before I was at the Press Club of India where I was doing a media briefing, and the lack of knowledge with respect to Ayush was just appalling. People were like, why do we need this allopathy? We are curing cancer with Ayush. And I was like, it's not about, and they started linking it with nationalism and with pride. And I said, it's not to do with anything of that. We are very proud of our traditional medicine, but we do need some evidence that when and where do you use Ayurveda? When and where do you use Unani or homeopathy or whatever it is, and how does that align with what you're doing on the allopathy side? So nobody is against anything. And I was leading an integrative medicine initiative at Niti Aayog. But we made no headway because even within the Ayurveda community, nobody could agree on the principles we should follow for research. I said, you don't agree with modern medicine, that's fine. But what are your own principles? You will have to define. We are sitting in 2026. We can't keep saying it's just an ancient medicine and we don't need to show any data or any evidence. So I think we need proper studies, proper research when we talk of integrating Ayush with modern medicine, and not just delivery. Just giving out more Ayush medicines is not the solution, because people are really confused, which includes health providers, which includes patients. Every day I get patients coming to me saying, we are leaving our medicines, we're just going to take this XYZ Jari Bhuti. And I'm just like, no, 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 please wait, don't do that. Ask your doctors. So this is the reality of the population. And we are not coming out with the evidence, we're not coming out with the data. Nobody is dismissing Ayush. I'm the first one to say, it's our traditional knowledge, we must build on it. It has to be in a sensible, scientific, systematic manner. So I think I completely align with you on that I would have really liked to see more going into this kind of research studies rather than just these tertiary institutions, or where we're just talking of service deliveries. We need more research. We also need more research on environmental links, of what this air pollution is doing to us. It's not just lung cancer, it's causing all sorts of things, right? From dementia to everything possible, raising blood glucose levels. So we need studies on that, right? The water we're drinking, what it's going to do to us. And I didn't see that in this. So I think that is how I would put it. Overall, we always like to be positive, so that is a good thing. But as I said, I feel that there's so much more that should be going into this sector. I feel that all the allocations that you make in your other sectors, whether it's education, whether it's infrastructure, if somebody is not healthy, all those allocations are meaningless. I cannot study, I cannot work if I'm not healthy. And I feel that, almost coming up soon in, sometime to 80 years after independence, we still are not convinced of this. That really worries me. And I don't know what will change that. Honestly, I've spent my whole career even now, even though I live with such a serious health condition myself, I spend all my time trying to convince people that health is not an expense, it's an investment. And I don't know, whether I'll see that shift in my lifetime, but I think that is what we really, really need to see, and not incremental measures, not being happy with few things here and there, 5%, 10%. I don't think that's going to get us very far. So I'll conclude here. Sorry, as I said, I'm not very diplomatic. I can
Thank you.
I can
Thank,
often be very, very brutally honest, and many people don't like that. But yeah, so I think that that's where I'll end. Thank you.
Thank you, Dr. Urvashi, for these very, very extremely important reflections. They have added actually valuable perspective to our discussion, and now we can further deliberate on. And later on, I'll be coming to you maybe in the end. Now, I request Dr. Praveen Aggarwal ji his topic is financing India's health system, and he can extend it a bit, share his own experiences. Over to you, Dr. Praveen Aggarwal ji.
Thank you, Manorama. It is honored to be part of a panel led by my dearest colleague, Dr. Manorama Bakshi, who is heading our public health and policy vertical. And it was a very great opening, Manorama. And Urvashi, after what you said about hits and misses and more about misses, I don't think there is much left for any further speaker to add on. So I have a bunch of papers, I've done a lot of research over the last few days on what I should be talking about, but both of you have already stolen the show. So I'll rather try to uh, focus on some of the points which are either not covered yet, not necessarily only about the budget, but overall, what do we need? And I'll try to address some of the questions that Dr. Urvashi has pointed out, and she's seeking answers. One thing I would like to tell you, Urvashi, we are pretty certain that in our lifetime, in your lifetime, you're going to see structural changes. I'm very optimistic and hopeful about this. We have met some very good health bureaucrats and health technocrats in central and state government. They do have very good intent. We have seen major national policies getting changed or made in a span of 1 year's time. Though they are bound by their own bureaucratic processes, etc. I think collectively, if this group and many more, we are able to identify such bright sparks across the country and create a momentum, we are sure we'll have these changes done. The world is waking up, and our youth is very much concerned about the health ecosystem, and also they are looking at creating a whole lot of startups to look at many of these problems, etc. Now, when we talk about the health budget in today's context, the question is not really whether the allocations have increased. They've clearly increased. Manorama has also mentioned, Urvashi has also mentioned, though maybe 10%, which seemingly looks insufficient. I think what we need to see, or the important question is whether health financing is aligned to the kind of nation India aspires to become, the Viksit Bharat that India wants to become. And if India wants to become a Viksit Bharat nation, then are we really concerned, caring about our population? By 2047, we are going to have a much larger genetic population. We may not have that demographic dividend of the youth. So are we prepared to spend on our people's health and wellness, including the mental health? And that is what is the foundational pillar besides education, which is going to lead us to Viksit Bharat, not the machines, not only the technology or AI, etc., but are we doing the right things? So the budget overall, besides 1,05,000 crores, lakh crores that both of you spoke, it is actually about 1.25 lakh crores, including spending on insurance, innovation, research, digital health, and IUs, etc. This directionally is reflecting a change in thinking, shift in thinking, and also only from looking from health welfare perspective or a socialistic perspective to start thinking about the national capability to deliver on the promise that we have made to ourselves, our leadership has made to all of us. Now, there are three broad realities which are again re-emphasized by this budget that we should be cognizant as we proceed further. Health spending 2% of GDP, but if you convert into per capita, that's about 2 rupees per person per day only. And I mean, this is probably less than cost of a cigarette or whatever we call it. So too negligible if we look from that perspective. Out-of-pocket expenditure for people in general remains about 50%, so which means For every 2 rupees that government is spending, 1 rupee a person has to spend all by himself, and states are able to deliver about 65 to 70% of health services. So these data will be relevant as we proceed further on how NHF funds are being utilized, etc. So what has virtually happened with this kind of budget allocation and budgetary provision? India has become principally a privately funded system of healthcare, as major expenses are being borne by people like us. And we are looking at sustained productivity growth. In such a situation, health cannot just be looked at absorbing the shocks, but it has to reduce structural risk for the entire population, for the entire country. Few things I'll start from. So if we look at per capita spending again, so it's about 700 per person per year. Now, of this spending, we are expected to finance prevention and primary care, public hospitals and insurance, medicines and diagnostics, mental health, women health and Ayush, digital health systems and surveillance. Now, one, our system is weak and leak. The implementations are poor. So the implication is the efficiency is marred. The sequencing or the prioritization of this budgeting may not be always right. So what we need to probably see, instead of just looking at headline increase of say 10% or 12%, can we do right kind of prioritization, which is basis efficiency, the health outcomes, the return on capital invested. So some critical areas where results are faster, better, measurable, can we start to invest more? There are some policy constraints which are required to be addressed, which I'll come in a minute. If we talk about insurance versus primary care and the implication of that, so while PMJ covers about 50% of the population, and there is a very large budget estimate of about 33,000 crores or 34,000 crores, the national utilization is about 62 to 65%. Now, this looks like a structural mismatch in the way while households are spending 60 to 65% from their own pocket, on the same hand, the budget seems to be underutilized at NHM. Now, even if there is a redirection of 5 to 10% incremental PMJ growth towards primary healthcare, primary diagnostics and medicines, this can avoid unnecessary admissions, long-term health burden on poor as well as middle-class population. So some thinking is required on structurally where to guide PMJ allocations, etc. Public hospitals, there is a budgetary allocation. Now, is it lopsided? Is it getting spread? This infrastructure investment is happening in district level or at the taluka level. That I'm not sure, but the evidence is showing that we are still making the tertiary care investments or infrastructure investments in the larger towns. So we also have to see when we at one end we have PMJ Yojana, which is letting poor and rural people avail healthcare services, which means increasing the demand, but not having appropriate infrastructure in those places. So that is going to lead to mismatch. There are one or two interesting case studies. One is of Tamil Nadu. So Tamil Nadu sees 92% of NHM utilization. And why is this happening? predictable operating funding, strong procurement, staffing discipline, and the result is capital investments are translating into usable services. Versus now, let's look at another case study, even more fantastic and implementable. In fact, me and Dr. Manorama saw a scenario in Odisha first time. We were on a visit there 2.5, 3 years back to propose some kind of newer innovation in brain strokes and few other diseases. And for the first time, we heard the health bureaucrats saying that bring us the proposal, money is not a constraint. If there's innovation, it gives a large benefit, we immediately take it up. So that was so much of a pleasure to the ears, music to the ear. So in Odisha, the NHM utilization is 104%. And that has been caused by rapid fund flow, administrative readiness to accept and absorb that money. And clearly, these two examples let us know that money is lesser of a problem, but absorption capability or execution capability, and even at the states, is more of a challenge. How do we overcome? How do we ensure that every penny allocated for health is spent wisely and efficiently, and is resulting into outcome? Linked to this is, if we look at the spending pattern, you would figure out that most of these spendings happen toward end of the March, because states are under pressure to exhaust the budgets allocated. That will impact their future PIPs as well. Whereas some high-performing states show 90% or over utilization. So now, what can we do? What can the future budgets look at doing? Can we link these allocations to the states, linked to, say, timely hiring of appropriate staff, timely procurement? Can we look at quarterly utilization, etc.? Can we look at some outcome-based release of the funds, etc.? Manorama, you can stop me when you think the time is getting over. So otherwise, I'm going to take another 2-3 minutes, and you know how this topic is dear to me. I can
Yeah, I know. You can speak, Praveenji, another 1 minute.
Okay, all right.
Yeah.
Now, in the manufacturing sector, we see government for last 4-5 years has introduced several production-linked incentive schemes, and that has given a lifeline, or actually that has created several new industries. Whether we see in electronic manufacturing, we have become the leaders in exports and manufacturing of the mobile phones, semiconductor industries, solar industry, and many other. And these PLIs have become very successful. Can we not think of having similar kind of either efficiency-linked incentive scheme or outcome-linked incentive scheme, or even infrastructure-linked incentive scheme for creating rural healthcare infrastructure and incentivizing the private sector to establish there? And that will address, Urvashi, one of the questions that you also had, whether this 2% is going to suffice ever. So while I have the question about the efficiency and outcome of the 2%, but this 2% surely will not suffice. How can this 2% can become 6%? That will not happen without the private capital. And can we look at health infrastructure being financed in a manner that we look at structurally changing and looking at 10-year operational financing plan? We also determine explicit funds commitment from the states around this. And there are a few more things that I like to talk. So most importantly, the policies about AI and digital health. We have seen several examples where, despite advancement of artificial intelligence and digital health, our policies have still remained rudimentary, and also probably outdated. And this is natural because in today's world of innovation, the product and processes, like when we had a online Uber cab, there was no policy for aggregation of such cabs. So government understood in 3-4 years time, they tried to bring a policy. When these smartphones came, people started to talk about data protection, etc. Now we are trying to have a data protection policy. So I won't blame government for this. I'll give you one or two small examples. So despite advent of AI and most of the pathological test report being made by AI tools, etc., even now there is a requirement to have a pathologist at each of the path lab. And do we really have these kind of trained pathologists? We don't have. So can the policy not provide that for 10 such labs, if there is one physical pathologist available, that should be a good idea. Similarly, there is so much of advancement happening in dialysis care, but we still want one MBBS doctor per such center. Now imagine if we have to provide dialysis care to each of the suffering patient who needs dialysis care in the country, we need roughly 225,000 dialysis care centers against only about 10,000 right now. So one, I don't see the policy allocation, budgetary allocations towards that. But do we have these many doctors who can only be looking at dialysis care centers? So I would want, going forward and towards the closing, if we can look at outcome-based budgeting exercise, we can ensure release of budgetary provisions on the basis of reviews and appropriate spending by the states and other heads. Focus on some policy and structural changes, which may not be a financial burden, but these structural policy changes can actually make delivery of healthcare services at all levels much better with the same kind of allocations, etc. There is a lot more to do. We remain very optimistic. We have at Consortia Advisory successfully intervened at least in 10 major policy changes, including getting respiratory diseases included into NCDs, getting brain stroke guidelines revised, etc. So there are people with the right mindset, right heart in the healthcare professionals. The budget is in the right direction. Lot more can be done surely. But more later. Thank you.
Thank you. Thank you so much, Praveenji, for situating this within the India's Viksit Bharat vision while highlighting persistent out-of-pocket costs and the need to explore efficiency-linked approaches for structural changes, what you mentioned, especially in the rural healthcare. Now I request our another panelist, Dr. Varun. He'll be speaking on population youth SRHR in the health budget. Over to you, Dr. Varun.
Yeah, thank you, Dr. Bakshi and fellow speakers for setting the tone. And I am honored to be part of this panel discussion. You know that this union budget came at a decisive moment in India's demographic transition. Fertility is declining, aging is accelerating. We talked about that, and dividend window that we talk about, and we are proud of that also, that we are a young country. It is going to be declining and will start narrowing after 2031. So you know that in this context, population health, especially women health, safety agency, and youth participation are not just a social sector add-on that we most of the time talk about in budget, but it is a core economic imperative. Because what budget choices today we make, that will shape future outcomes. So as we are talking about that, are these current allocation aligned with the shrinking demographic dividend window? That is the question we should be asking. I will not be going into the total union budget, that we know that definitely there is an increase of 7.7%, and fellow speaker also talked about that, that health budget as overall, there is a 10% increase in the allocation. But when we put that into different perspective, and Dr. Praveen also talked about that, per capita allocation is mere 745 rupees per person per year. So that roughly translates into 8 USD and about 2 rupees per person per day. So, and this does not include state spending on or out-of-pocket health spending, but China and Brazil, the other countries that we can definitely compare, spend more on per capita than India. So the real question is that, can 2 rupees a day central government allocation meet healthcare needs of population of 1.3 billion? That we should be thinking about it. The other important aspect of the budget, when I was also analyzing the union budget, that last year, if we compare that, mid-year adjustment in health budget led to a downward revision and cut of 3,000 crore in financial year 2025-26 when we see the difference between budgeted estimates and revised estimate. So this also suggests something, that these cuts suggest that maybe because of these cuts, there is disruption in the services for those who rely on public health system for healthcare access. The other thing, Dr. Bakshi, you also talked about that here, the relative share of health budget in total union budget remains stagnant at 2%. That signals that, that again, it signals that sector has not gained additional fiscal weight in overall union budget this year itself. And that has been stagnant since last couple of years, 2%, and it has not increased much. Then when we deep dive into health budget, then we see that National Health Mission still remain the backbone of public health system, and it is good to see that the allocation has increasing. But whether that increased allocation is as per the expectation or whether it is meeting the need of the increasing population or not. If we see NHM allocation, it stands at 39,390 crore this year, and Flexi pool for RCH and health system strengthening that received 31,820 crore. This is a 6.5% growth over revised estimate as per last year, and capital outlay remain almost nil in NHM and Flexi pool. Now, why this Flexi pool for RCH and health system strengthening is important? Because all schemes under NHM are clubbed into that one, and this pool matters because it enables transfer to state for decentralized health planning, and all components like reproductive health, maternal health, child health, newborn health, and adolescent health program. All provisions and allocations are put into this particular bucket, and there is a 6.5% increase from last year revised estimate. Now, see, we know that that NHM serves the largest share of India's population, especially in the rural area, which constitutes 63% of total population of India. So the real question we should be asking whether this limited growth in budget allocation for NHM and RCH flexible is enough, because this limited budget allocation may constrain improvement in coverage as well as quality. The second other important aspect is family welfare funding. That has declined 1% when we compare with the original budget outlay. Though there is a marginal increase of 1.7% when we compare it with the revised estimate, but again, this increase is marginal and insignificant. Now, why this family welfare funding is important? Because this support outreach, frontline worker training, maternity care, and contraception. And here again, budget signals low fiscal priorities. And flat funding may limit demographic dividend for sure. One good thing that is in the budget is that the budget also talked about mental health, and fellow speakers also talked about that. And in budget speech, Honorable Finance Minister also acknowledged this through commitments to NIMHANS, upgrading regional mental health institution, and expanding emergency and trauma care in district hospital. But I was looking into the data also, and however, we found that that suicide is the leading cause of death among youth aged 15 to 29, and this is coming from causes of death in India 21-23 report. Yet when we see the budget commitment, that National Tele Mental Health Program, that allocation shows a sharp decline from budget estimate levels, with 36% reduction from last year budget estimate of 79 crore. And even when we compare with revised estimate level, that was 45 crore, there is a just 14% increase, which is insufficient for a country with 365 million youth aged 15 to 29. The other aspect that I want to touch upon is on women scheme related funding, though that is not coming part of health budget, but statement 13, that women constitute equal half of the population, yet gender budget accounts only 9.4% of total union budget. Though it has increased from last year budget estimate, or if revised estimate share we see, it is 8.9% or 8%. But again, that 9.4% for women in the total budget is like really, really concerning. Overall, if we see, gender budget has increased 26% when we compare from last year revised estimate. But again, when we compare it from budget estimates, it's 12% increase. The most striking aspect is that the part A component of gender budget, which reflect 100% allocation for women, it continue to hover around 20%, and most of other the funding or increase is going into part B component. So then it also point to limited accountability for gender outcome, because if 100% allocation is not increasing, it is very difficult to health system accountable for gender related outcomes. I would like to stop with this statement only, that that overall, while the budget recognize India's health challenges, yet fiscal decision prioritize control over scale. Population size is acknowledged definitely implicitly, but not funded explicitly, and sexual and reproductive health needs are almost neglected. So definitely, if we continue to have flat funding for SRH, there is a risk of foregoing potential gains. Thank you.
Thank you, Dr. Varun, for underscoring why the RCH flex pool matters. You spoke that nearly all the RM and CHE provisions sit within it, and limited growth with a marginal decline in family welfare funding raise important questions, especially given India's 365 million youth, which you raised, and rising suicidal rates. Need a translate like a 25% increase in the gender budget now. That is another thing you stressed upon. So thank you very much for giving us these insights. Now I am moving, since I have the time limitations, so I am moving to Dr. Sanghmitra Sheila Acharya ji. Her topic is health of the vulnerable populations. I really want to hear to this her perspective and her insights. Dr. Sanghmitra ji, over to you.
Thank you so much, Dr. Bakshi. Thank you for organizing this almost every year that I've known for past few years. I think it's a very important discussion that we need to have, how budget, aligns or doesn't align with so many different aspects of our life. So much of the matter which is kind of important in context of, today's lives, my predecessors have already kind of shared. So what I'm going to do probably is take you straight to one of the elements within vulnerable populations that I would want to engage with. We kind of fairly agree that there has been, the health sector has received some incremental change from the last year's budget, about 7% or so. Nevertheless, we've also pointed out that how do we translate this increment that we are seeing over the budget? So a couple of things which we kind of notice in this budget as perhaps, if I may say, as pointers, three important things which to my mind become relevant in this discussion today. Mental health, as my colleagues have already pointed out. The second is about the affordable care, particularly for the NCDs, which includes cancer. And we've had Dr. Prasad talking about on it very, very elaborately. The third constituent, I think, is also extremely important, is where the biopharma hub is supposed to be, where, is getting a strategic push, so that India can be positioned in terms of a major producer for that matter. I would really want to kind of point out when we are pushing this biopharma, how much of alignment are we seeing in terms of environment, in terms of the, if I may say, the flora which will be engaging with the biopharma for that matter. The other element, I think, if you look at the affordable, treatment or affordable medication versus the biopharma part of it, a lot of focus has actually been on the skilled healthcare workforce, which perhaps is going to address the rising disease burden as we envisage it. What is perhaps important for us to take note of, and again, Professor Prasad pointed out in terms of the deficit that we have vis-a-vis health research, while we see that the allocation has risen almost by 24% as compared to the previous year, this allocation is included in the total resource allocation of the total budget for that matter. Health research is there, which seemingly has increased, the total budget being increased to 7%. Now, as we move ahead in terms of, seeing how this increase in the research budget, which in quantum terms has increased from to about 4,821 crores, to be precise, as the budget outlays from last year's 39,000 crores. Now, while we see this increment happening, how much of the health expenditure as a share of total government budget remains around 2% is where we become, where we get stacked. So despite these increment that we are talking about, how does this increment translate into what becomes really affordable in that sense? Reducing the out-of-pocket expenditure perhaps becomes very, very important. Just to take a call on how the budget allocation for the National Health Mission has happened. Here again, we see an incremental kind of trajectory which is visible from the last year, from 15,036 or 37 crores to about 1,524 crores. Now, while this other sectors, we are seeing an increment. The sector which is family welfare, and Dr. Sharma has just pointed out, seemingly has fell by 1.6%, and this probably becomes very important in the context of the demographic, trends that we are having. When we're talking in terms of the fertility transition, we're talking in terms of what we had been envisaging in terms of containing the population growth. Here is the moment where we need to capture and capitalize. We are unable to, the budget doesn't really inform us much on that count. The other point in the same context, perhaps, which becomes important is when we're talking in terms of, specific 17 drugs, to be precise, for cancer, having the custom duty has been reduced, and Dr. Prasad has already pointed out that there are hundreds of them that we import, and this we're talking about only 17. How is that mechanism being put in place to be able to ensure that those of us who need these drugs will be able to access it? So while provisioning is being made, the roadmap for access is still not very clear, particularly for the vulnerable populations that we might want to think about. Nevertheless, therefore, I think what also becomes important at this point, and I'm not getting into the details of what Ayushman Bharat, etc., because both three of my colleagues have already spoken about it, but I do want to point out In this kind of prepositions that the budget has given us today and we are deliberating on, I think it has also fairly noticeable that there is an element of underutilization of funds, especially if you are looking at National Health Mission. It, in fact, very categorically informs that only 62% of the total budget 24-25 was utilized. So funds are there, and we need implementation of the policies that have been put in place. Directions are there, but the implementation is not happening. Now, in addition to that, another element is the regional disparities. Take any development indicator, and if you're very well aware that there are regional disparities. Now, there are significant variations in spending across state also because of the propensities of different kinds. So that affects the uniform delivery of services, I'm sure. We'll all agree, particularly to the vulnerable populations. Now, I wish to connect the vulnerable populations to the realm of mental health and trauma, wherein the budget kind of takes cognizance of how mental health is important. Now, while this budget is announcing that a second national mental health institution will be created to address the regional gaps, emergency and trauma care capacity in district hospitals will be expanded almost by double. They'll be doubled, in fact, especially when the institutes which are already existing in places like Ranchi and Tishpur are going to be upgraded, and there'll be measures in order to target poor and vulnerable populations which are exposed to health shocks and health emergencies. Now, health shocks and health emergencies are generated largely by the physiological condition in which we could have our health laden. The other element which I want to connect this realm is also with the injuries. Injuries, particularly in terms of the public health concern, because if you look at injuries, they contribute to a major share of, if we say, wherein our healthcare expenditure lies, particularly the out-of-pocket expenditure. Injuries are one of the major deterrents in terms of the care provisioning or the whole system, if we might want to take it. And within that, road traffic injuries become a very important cause of disability, particularly in South Asian scenario, India for sure. And it also connects with the young population to whom we are pegging so much of our demographic dividends. So I want to therefore make this as a point that road traffic injuries are important in context of the budget, particularly this year's budget, wherein the trajectory is intersecting with not only the public health priorities, but also the demographic dividends that we are, kind of hinging on. I mean, I'm sure till now, we haven't really seen the road traffic injuries very explicitly being foregrounded in the budgetary allocations. They're embedded largely indirectly in the various relevances. And that's why I'm trying to hinge them on the mental health aspect, trauma care aspect, because trauma care is something wherein we go by whatever provisioning of the care is also being put across. So when we're looking at trauma care being put in place at district level, government, functioning vis-a-vis different facilities being upgraded, it also connects us with what the economic survey of 2025 suggested to us in terms of the very notion of mental health as a major concern. Now, mental health, injury for that matter, regular injury also influences the mental health of the individuals, which again burdens in different ways. Now, if I want to take this forward in terms of what exactly, therefore, we need to take cognizance of while investments if I may say, in tertiary care health institutions, as in the form of trauma care facilities, emergency medical facilities, need to be improved in terms of the crash survival and the injury outcome. And the point I'm trying to make is, while we have, for example, the PCR vans on the roads, and you have the facilities maybe at a certain distance from wherever the PCR vans may be located, what is happening in between in terms of the functionality of how the trauma care can be reached out to somebody who is experiencing road traffic injury particularly, is where we need to peg ourselves in. There's a fairly big blank that we are not able to, as of now, think about. Expansion of medical education, for that matter, and allied health, for which we are already seeing in the budget. Probably it can be factoring in how the medical education will sensitize through the syllabus, and the allied health workforce be trained in terms of strengthening the not only the trauma at the point of occurrence, but also at the stages of rehabilitation, because rehabilitation, let's recall, is also influencing the means of livelihood, sources of livelihood, particularly if a long-time disability sets in post trauma, post injury, and therefore I'm trying to peg it in the consonance of all the three pointers that I'm trying to say: mental health, expansion of the services that the budget is proposing, and also the NCDs or the critical care realms that the budget is posing for ourselves. So I think the gaps which are in terms of the limited focus on prevention, if we may say, that's where perhaps the other sectors will get involved besides health. Budgetary priorities can actually, be addressed in some ways in terms of, let's say, determinants of RTI. We haven't really put ourselves in place in terms of, the road designs, for example, the signage on the roads, for instance, how weak or strong are the enforcement of the traffic rules, for instance, and also the inadequate trauma systems. I know they sound more like, prepositions which can be limited as wishful thinking, but I see a very strong connect with the 3 pointers with which I started looking at the budget in terms of, I thought, why it becomes important for us to look at the accident per se, and particularly those which are vested in the road traffic. Also, it points out to, and I relate this with the research part of it, a lot of there's a gap in the data itself, and there are factors which lead to this gap. The data and surveillance, which is a gap which is existing, I think also limits, how we can actually make the surveillance and the health information system, therefore, make them responsible, don't constrain them in terms of creating that evidence by way of perhaps road safety planning. Connecting this, and I'm very consciously kind of saying this in terms of how the vulnerable populations will be the ones who will be most badly affected if this is not taken into cognizance. A lot of vulnerabilities that we are talking in terms of what budget may have not done about to the vulnerable populations, although we're trying to say the allocations through the existing programs have increased, and therefore the access to the vulnerable populations will become better. But my problem again would be, and my other colleagues have already mentioned, the implementation part of it, which is crucial in creating awareness about these programs and creating that environment through which these programs or schemes can be accessed. I think that becomes very important in terms of taking on board the vulnerable part of the populations. Vulnerability, and we know that can exist in terms of gender, it can exist in terms of social identity, physical disability, regional distances, and so on. We do have specific concerns over that. For example, the budget supports upgrading of the healthcare, including new medical colleges, etc., which will be built in. The National Health Mission, like I said, already points out towards an increase. The government aims to cover 10 crore poor families under the health program, providing up to 5 lakh per family. But then, like I said, accessing to this 5 lakh per family on one hand, and two, in case of certain conditions, is this amount enough? What are the provisions, alternative provisions, therefore, which can be made available if the need be? What is happening to the physically remote spaces where most of the services it's difficult to ensure that most of the services will be able to reach. So with some of these points, I think I'll stop here. I understand the time constraint. In fact, the sub-plans also, the targeted social schemes, which are tracking, specific plans like tribal sub-plan or the special component plan for the scheduled caste, while the allocated funds seemingly have improved, but the actual utilization of the funds is where the concern becomes important. I'm going to stop here, Dr. Bakshi. I hope I haven't exceeded the time, but then I'll come back if need. Over to you. You're not audible.
You're on mute,
Dr.
I think.
Sorry. Thank you, Professor Acharya, for underscoring the affordability and cancer care priorities while flagging some very important, you raised issues like underutilization, data and surveillance gaps, especially in road safety, and their disproportionate impact on the vulnerable populations, including the tribal populations you address. Just due to paucity of time, I'm not elaborating my comments. Now I am going to Dr. Shoba. Dr. Shoba will be addressing nutrition and human development outcomes. Dr. Shoba, over to you.
Thank you, Dr. Bakshi. And it's very difficult to go after such eminent speakers. I've already elaborated so much. Thankfully, I'm not talking on health. I'm going to be talking on nutrition. And I totally acknowledge what my previous speakers have talked about, the lack of gender budgeting or the lack of importance being given to the vulnerable sector, wherein I want to talk about the women and children and the last mile connectivity. And nutrition has a similar scenario. I mean, I think the budget increase is very tokenism kind of an increase. And it's similar for nutrition, which is one of the most binding constraints when we talk about human development. Despite programs over decades, we still see undernutrition is quite high, wherein we see almost 1 in 3 children are still stunted and 1 in 5 children are wasted, and more than almost 50% of the women in the reproductive age group have anemia. So I think a lot is being done, but it's not enough. I mean, certain things need to be implemented at the right stage to have some kind of a positive outcome. And nutrition is something, I think it's got a long lasting impact, wherein we talk about learning outcomes or we talk about labor productivity and even the intergenerational mobility. So if I come from a policy perspective, I think the message is very clear that undernutrition is no longer just a social sector concern. It's more of a macroeconomic and a human capital issue. We've been talking about demographic dividend. I think it comes across very clearly why we need to work on, these nutrition indicators. And there have been countries who have shown that if you invest in, treating the long-term investment in nutrition, they have shown great results in terms of overcoming malnutrition. Specifically coming over to the budget, it's there has been an increase which is very incremental, which is just around 10% from the revised budget of the last year. And the core budget also for the child has also increased, which is like not much. I mean, some point percentage there's been an increase in the child budget. This shows that there is a recognition, but it's almost minuscule, you know. It's very small for a fiscal footprint when we talk about children, especially for an expanding economy like India. And if we come over to specific on the nutrition budget from the Ministry of Women and Child Development, wherein we see that a lot of the portion has gone to the Saksham Anganwadi and the Poshan Abhiyan 2.0, but however, that is still less to some of the evidences on costing which is available of how much is required to invest in nutrition sensitive as well as nutrition specific interventions for impact to be shown. I mean, just to give an example, there have been costing studies which have shown that it's required in the tune of 38,000 to 44,000 crores, specifically on nutrition interventions. But then when we look at the budget, which is around 23,000 crore, which is a marginal increase from the last year budget, I don't think it is going to be able to suffice in terms of bringing about an impact. And also, secondly, there's an important aspect of utilization. I mean, we have evidences from Niti Aayog which say that many of the states are not utilizing the budget. That not only reflects on you know, particularly why the funds need to be utilized, what is the innovation they need to do, and what is the kind of capacity building and skill they need to build for the workers who actually are leading the work on nutrition from the community front. And also the budget, if you look at the deciphering the budget, the 2026-27, it does very little to directly look at absorption constraints at the district and the block level. I mean, there's not much of a change that has happened from the last year. And coming over to the important aspect of frontline workers, I think they still remain underfunded. The workers who are expected to deliver so much in real time, but hardly are they are not. I mean, in terms of the salaries or in terms of the infrastructure, they are not actually funded enough. And you know, the technology can be very helpful, but again, there is a lack of skill and capacity building in terms of how that technology needs to be used when you talk about a portion tracker. So I think there is a lot that needs to be done to be actually able to get a result on in the community. And finally, I would also like to say that convergence remains very, you know, rhetoric. And because Poshan Abhiyan comes across as a multi-sectoral mission, wherein we need to also look at the nutrition-sensitive interventions like wash and health and the social protection. But when the budgeting is done in silos, there is no intersection between, there's no convergence between these sectors which are actually aligned to bring about an impact. So I think till the time there is a convergence happening and the budgets are developed so that the intersection is worked upon, I think there will be definitely a big gap. Just to say what are the priorities, I think I'll just precisely say there could be 3 to 4 priorities which need to be done. First, we need to move from a clear roadmap, you know, just from increments, we need to go over to adequacy. There has to be a clear roadmap that closes the gap between the current allegation and the evidence-based interventions. Evidence of what is needed to be actually able to overcome the situation. Secondly, I think there is a need to invest in absorption capacity. We need to look at schemes at the district level, the planning units, and the monitoring system, so that the local institutions can actually say what is the predictable funding, what is that they require. It is not that one solution fits all. Thirdly, there should be some rebalance in investments towards the frontline workers who are the backbone for the nutrition food security program in our country. And lastly, again, as I said, convergence matters. So I think nutrition budget as a cross-sectional outcome, not to stand alone, not as a standalone scheme, but also looking at health, wash, and maternity benefits, the PDS, and the livelihoods. They must be aligned through shared targets and indicators rather than just left to, converge informally at the frontline level, at the frontline worker level. So I think there is an urgent need to restructure how we look at the food security, especially for the vulnerable. When we are looking at the demographic dividend of having a young population, I think this is something which needs to be looked at from the budget point of view and specifically look at what is the need. A particular state might have a different need than the other one. There are smaller states, there are UTs. So I think we should not have a one solution fit all. I think there should be specifically customized budgets allocated so that some of these gaps can be covered and we can look at a better scenario in the coming times. I would like to stop there.
Thank you so much, Dr. Shobha, for highlighting that nutrition still remains an intergenerational and macroeconomic challenge. You address some of the very, very pertinent issues like uneven utilization, frontline capacity gaps, and too much of workload. And you address that weak convergence continue to constrain the outcomes. I completely agree with you. For more than 25 years, I have also wanted to have some kind of convergence between the ministries. It is still a pipe dream. Agree with you. Now, coming to our panelist, Dr. Abhijit ji. Last but not least, so Dr. Abhijit, over to you. Budget and public health he'll be talking about, or whatever you wish further, like what you feel has we have missed on. So you can add on those points. Over to you, Dr. Abhijit.
Yeah, first of all, I'm not a doctor. My PhD was not completed. But anyway, that's a passing remark. But then, the last speaker in the panel being the last speaker has its advantage and its disadvantages also. So obviously, one way of looking at it that, I just sum up whatever everybody said. But I think then Arjun and Dr. Bakshi will, start beating me up. So then
No, no, not at
I'll not,
all. You
I'll
please do
not do
that.
that. But what I would rather try to do is that I would try to, usually what happens is that in the panel, because, for last year due to a small accident, I could not come. But then for this is probably sixth or seventh year continuously, I'm coming into this panel. So generally, I am the skeptic, I am the possibly slightly pessimist, but then let me flip that because the way other speakers spoke this time, I think let me try to contextualize the entire budget allocation. I think everybody, all of those esteemed speakers, in fact, talked about the allocations because in some very explicit way or some in a slightly implicit way. But then the point is, the larger macroeconomic picture is. Related to the fiscal deficit. It is as simple as that. So the point is, if we have to, as budget proposes to do this year, to put the fiscal deficit somewhere around 4.3% of GDP, because of course, it has gone down below 4.5%. So obviously, then at one level, it is pretty simple. Basically, your revenue minus expenditure is your deficit. So obviously, if your deficit, if you want to keep it tight, then definitely what you have to do is to cut down on expenditure. If your revenues are not increasing, and all of us know, I'm not getting into that macro broad picture, why it is so. Because in today's turbulent world, it's very difficult also. It is understandable at one level that revenue will not increase. It will not take a quantum jump. That is what I am trying to say. But then the unfortunate part of it is that if due to this cutting down on expenditure, if it comes mostly to the social sector and particularly health, then it becomes a bit unfortunate. That part I agree, with all my colleagues here. There is no doubt about it. But, as I said that I am trying to give it a spin from the other side, for the debate's sake. Usually I play the devil's advocate, but I am just playing the reverse role here. But if we see the point is that, the last full decade, if we look at the way allocation, the absolute allocation I'm talking about. Of course, I'm not pegging it, or I'm not putting it as a proportion to GDP itself, which of course, should be done. That is the right way to do it. Even I believe that. But, to have some kind of a positive, I think, mark into the entire health budget allocation, I would rather say that, in the last 10 years, if we look at it, then there is a sufficient increase in that entire point is that ultimately, in absolute terms, the amount of rupee has gone up. There is no doubt about it. Now, having said that I when I was looking at the budget, with my limited, of course, Shoba is here. Shoba was, my colleague at one point of time, and Urvashi and other people are also there. They are all very competent on this. But what I find out is that there are a lot of good identification as far as health is concerned, in this budget. There is no doubt about it. Everybody talked about mental health because, it gives a good kind of, I would say, messaging, public messaging. In terms of public messaging, when the finance minister starts talking about mental health, trauma, and these kind of things in the budget speech, it actually puts it in a quite, I believe, in the focus. And it's a good thing. There is no doubt about it. Of course, but then it comes to, the brass tacks, basically, or to put it simply, how much is getting allocated there. So there is a problem because that is the first place that I can say. Then, there has been, even in the flagships, because Ayushman Bharat, that entire Ayushman Bharat, and PM Abhim also, the entire health infrastructure mission. These two are very, very critical, because particularly PM Abhim, because why I am talking about it, because somebody actually talked in the panel that there is a problem in the allocation on the primary care side. Absolutely true. There is no doubt about it. And PM Avim is supposed to do that. But the kind of increase we are seeing in the PM Avim is not, I don't think it actually goes into that zone. The point is, it is somewhere around, I think, 4,770 crore. If we look at our population, if we look at our budget size, forget about GDP, even if we look at our budget size, compared to that budget size also, it is not a very adequate kind of a thing to do. Then, in a related way, it comes to the tertiary care, or the cutting edge, the entire cutting edge health. The identification absolutely spot on, because in the entire this SSY, and then, establishment of new aims and those kind of allocation, it has gone up to, I think, 11,300 or something like that, 300 crore or something like that. So then the point is, identification is absolutely fine. But then there has to be a balance. There has to be a balance between primary care and the secondary and tertiary care. Here, actually, we are seeing that the tertiary care suddenly, getting some amount of money, which is good. I am not opposing that. It should be there. But should there be some, proportionate increase in the primary care? I feel absolutely yes. But, unfortunately, because of that broader picture, it did not happen. Now, once again, similar thing that I can see in research and development, for that matter. If we look at the entire health research part of it, then it is like 4,800 crore. Department of health research allocation. So, of which ICMR alone gets something around 4,000 crore, which is okay. I have nothing against ICMR. Let ICMR flourish and other kind of things. But is it adequate? Same thing, that Biopharma Shakti. Biopharma Shakti gets 10,000 crore over a period of 5 years, which means roughly around, on an average, 2,000 crore every year. So then, if we are trying to find out an ecosystem, or establish an ecosystem rather, in biologics and biosimilars, which is good. Once again, the identification is there, but not enough money. The point is that private companies, even if you look at private multinational health companies, they, in something like biologics and biosimilars, and in general also, they spend somewhere around 15, 18, or sometimes even 15 to 20%, of their entire earning on R&D. And if we compare the Indian farms, if we look at the private side of it, then they spend even less than one third of it. And many of them actually, they spend even less than the average, the country average. There is no doubt about it. So if that is the kind of a situation, should government put in their money into the research? Possibly, I think there will be a strong case for that also. But I don't know, then once again, that is also somehow lacking, somewhere. So then the point is that then how do we look at the entire budget in theme wise? So of course, I think the idea is that in terms of GDP, of course, we are inadequate. The allocations are inadequate, and of course, I agree with what has been said about the health expenses, because it is not even an investment. On top of being a human capital investment, I would rather also say that health is something for a country like India, which has ambition to become one of the driving forces in the entire world and the world economy. So then, of course, it has to be a right also. These are health, education. I am not getting into the employment thing. It's a bit meddlesome. But at least the health and education should be treated as rights, rights of the people. Only then the things will change. Fine, cutting edge or tertiary care is getting strengthened, very good. There is no doubt about it. But what about primary care? So there has to be a little bit shift back towards the primary care. And then the way forward, I would say that, once again, reiterating every year that at least 2.5% of GDP, let's say by 2030 or something like that. Possibly, that is the way to go. And then some amount of redistribution, number two, so where we have, within our districts also, all over the country, there are underserved districts, and there are districts which are actually having a probably larger concentration than the national average. So there needs to be, within the available pool, there needs to be some amount of redistribution there as well. Reform, yes, of course, here only esteemed speakers, they again and again talked about the entire implementation, the, allocation is one thing, but then utilization of that budget, that is also very important. And not only that, how much money is getting spent in the ground, that has to be, that entire monitoring and evaluation part needs to be strengthened also. I think budget also should start talking about, not only in health, in all parts of social sector, monitoring and evaluation needs to be a part of the budget speech also, even if it is limited to, let's say, 3 to 5 sentences, but at least that should also come. And accountability, of course, there is no doubt about it. But it is not a budget. All of us know that it is not a budget which has not deviated from the long-term average trend of it, in terms of allocation, in terms of focus. Good things are that, the very important parts are identified, but definitely most of the times the allocations are not very adequate. Of course, that is there. There is no doubt about it. But still, let us be hopeful that this is very important, that we need a healthy population to become strongly into the path of economic growth also, and equitable growth, of course. Yeah, I'll just stop here.
Thank you so much, Abhijit ji. Now, to all the panelists, would you like to say last one-liner or something? Otherwise, Abhijit ji has already done the summation, and I will quickly have 2 lines to end it. In case somebody wants to say something as the last liner, you're please welcome.
Manorama, I'll summarize from my side, my collective thinking. So while the budget seems to be on a very good health trajectory across infrastructure, insurance, innovation, research, and digital systems, with the focus on mental health and Ayush. Mental health is a new subject which has been put into focus by economic survey as well as the budget. I think what we need to do going forward is to bring alignment within prevention and financing, insurance with primary care. How do we ensure that part? Capital with in sync with the operational cost and efficient operations, technology and human capacity. So, what kind of allocations, what kind of systems that we have, and finally, the Viksit Bharat cannot be defined by a number of hospitals only that we are building, but by the diseases that we are preventing, by productivity that we are enhancing or preserving, and the households which are protected. So thank you, Manorama, for this
Thank
very
you.
insightful
Thank you.
session.
Thanks, IMPRI. Over to you, Urvashi Prasad ji, or any of the panelists, if you would like to give any of the comments.
Dr. Bakshi, may I come in?
Yeah, please.
Yeah, just wanted to sum up, like you said, while the budget has strengthened healthcare infrastructure, it has, in some sense, in its limited emphasis, has remained on, like I said, injury prevention and road safety. Because, like I said, I am connecting this to the 3 thrust areas if we are looking at, and therefore let it not be a missed opportunity. Let's recognize that the road traffic injuries are critical to public health issues because it's translating itself in terms of what prevention can bring in, what trauma care can bring in, and therefore equity in terms of the interventions which are there, which can be made, also become very important and become essential in terms of reducing avoidable deaths, disability, and also therefore the economic loss. And like I said, I'm seeing the trajectory in terms of what economic aspects we haven't talked about, but means of livelihood are dependent on these. Just thought I'll make this point.
Thank you. Thanks. Anyone else, please? Urvashi ji or Shoba ji or Dr.
No, I
Varun?
think Abhijit has very crisply and defined and put it together. So I think I'm good to.
Urvashi ji, you would like to have some last line comment?
Yeah, I mean, I think I've already said what I had to. Yeah, so
Thank
it's
you.
fine.
Thank
Yeah.
you. Then in that case, like the last 1 or 2 line summation that I am going to say, I'm actually repeating your words only. Overall budget 26-27 reflects intent and incremental progress, and several of our panelists were cautiously optimistic about its direction. However, structural gaps remain in the financing design, primary care, nutrition, mental health, and protection for the vulnerable population. The discussion highlighted that outcomes will depend less on the headline increases and more on execution. The way Urvashi Prasad ji said, ultimately it's the execution. Convergence across sectors, जो शोभा जी ने हमें बताया था, and district level capacity building, ultimately strengthening the health as an economic infrastructure rather than treating it as a welfare alone, remains unfinished task. Thank you so much, panelists. We had a very good discussion and a lot of learning for me too. Thanks.
Thank you very much,
Thank you
Manorama.
again. Thank you again, IMPRI. Dr. Arjun, would you like to say something? Hello. Sana, somebody wants to end it?
Yes, ma'am.
Yeah, please.
I'll quickly say the formal vote of thanks from our end, and then we'll just wrap it up.
Thank you.
As we conclude this panel discussion on Population, Health and Union Budget 26-27, on behalf of IMPRI Center for Human Dignity and Development, New Delhi, I extend my heartfelt gratitude. Our deepest thanks to our chair and experts for today. Thank you to all our esteemed panelists for their insightful and thought-provoking addresses. Your expertise and perspectives have greatly enriched today's discussion and provided us with valuable takeaways on this critical topic. We deeply appreciate your time and contributions. We also thank all our participants who joined us live and contributed to today's dialogue. For those watching later on our YouTube channel, listening to the podcast, or reading our publications, we deeply value your engagement and interest. We look forward to your participation in our second Union Budget session today, Defense, Foreign Policy and Union Budget 26-27 at 3 p.m. and tomorrow on Gender, Social Inclusion and Union Budget 26-27. We hope you will continue to join us for future IMPRI Web Policy Talk and Web Policy Learning programs. Wishing you all a wonderful afternoon. Thank you.
Thank you. Thank you so much.
Thank you.
Thanks.
Thank you so
Thank
Thank you,
much.
Monoma.
Thank you, Dr.
Bye-bye.
Arjun.
Bye.
Bye-bye.
Thanks,
Yeah,
everyone.
thanks. Bye.
Thanks.
Bye-bye.